So tonight we're going to talk about a pain in the butt, causes and considerations. And for those of you who don't know, I think you all do, I'm the medical director and co-founder at LiveActive Sport Medicine. I've been doing sport medicine for a month or two now. And I'm happy to see everyone here, and I'll invite my co-host to say a few words about himself.
Yeah, great. Thank you guys all for coming out tonight. The Leafs don't play and the Cowboys suck, so hopefully no one's too distracted tonight while we're presenting. So I'm Marco, and I've been working at LiveActive for just over a year now at the Beaches location as a physiotherapist, and I'm happy to present for you guys tonight.
That's great. Thanks, Marco. Can we have the next slide, please, Brandon? We have nothing to disclose except that we're both active staff at LiveActive. We've received no commercial or academic funding, either financially or in kind, for putting this presentation together, and nor have we received any personal support of any kind to help us with this presentation. Next slide. And I'm hoping that really, and this is very personal, very personal objectives, review the causes of gluteal pain, review the relevant anatomy, and try and work on, refine, and develop a methodical plan for assessing gluteal pain, and we'll anchor that in a pretty complex case that Marco and I shared. And then become familiar with some community-based resources that you may find important and helpful for your patients with complex gluteal pain. When we think of injury taxonomy, it's usually acute or traumatic, or chronic and overuse. And this is sort of fundamentals of, MSK Medicine 101. But can you think of some causes of acute or traumatic gluteal pain that might present in the office or the emerge or wherever you're working? Don't be shy, please, because I'm going to pick on you if you're shy.
I mean, a simple strain can be one of the acute causes.
Proximal hamstring rupture.
Good old slip and fall.
Yeah, contusions, hematomas, yeah. Anything else?
I guess depending on the location, a pelvic fracture.
Mm-hmm.
In the chronic pain setting, we see acute aggravations from a myofascial component that often comes from above, that can feel to a patient like it's gluteal, but it may be referred from the QL or cluneal nerve, from just typically postural stuff or some, strains type activity that occurred on top of whatever was chronically there.
Yeah, and I think cluneal nerve entrapment is something that sport medicine doesn't see very much of, and I learned from it. I learned about it actually from my daughter, who's PM&R, interventional PM&R, and it was like, oh, okay. And so I've been trying really hard to make that diagnosis whenever is appropriate, I hope. Thank you. Anything else that's sort of more acute or chronic?
Pelvic floor pain?
Yes, in an acute or traumatic setting, what would that be? Postpartum?
Both.
Yeah.
A lot of people clench their pelvic floor all day long, so.
True.
It could be their postural glute muscle.
Yeah. And any other chronic overuse problems that you'd think about?
Like we being specific to glute max or in general?
Well, just gluteal pain. So no, not just glute max.
So I see a lot of like the piriformis pain coming from the hip external rotators working too hard. So yeah. Yep.
Just to add, sometimes the referral pain of the lumbar facet joints can go into the gluteal muscles.
Yep. And I think that would probably apply to acute onset buttock pain as well. Any other chronic things?
I mean, some of those, the facet arthropathy, discopathy, SIJ pain can, again, from a patient's perspective, be described as gluteal. But we often enough see a radiculopathy that doesn't present with distal findings. That seems like it's that lateral sacral region or maybe gluteal, that despite other efforts, maybe we end up getting an EMG and find, say, a L5 radic or an L4 radic that manifests as just that proximal set of symptoms.
Yes, and I think that's where sometimes it's very confusing, both to the patient and to the examiner in the beginning. Can we have the next slide, Brandon? So these were the diagnoses that Marco and I came up with, and I think we've covered all of them there. Maybe not the pelvic floor pain, Katerina. I think that that's a good one, but we could generally cover that in some of our muscle strains or sprain spasms there. And I think, you know, individuals who have history of cancer, even though it may be low likelihood of spreading to bone, I think one always wants to keep that in the back of your mind, that there may be something cancer related, even with a remote diagnosis here. So traumatic fracture, pathological fracture, even just metastatic bone disease before it's fractured. Next slide.
A patient with glial cell on his nerves in the glutes.
Yes. Yeah. And yes, exactly. Some of those other more are less common neurological tumors are odd and hard to present and hard to discern, I think. So yeah, no, that's a good point. Marco, I'm going to let you take over.
Sure. So we'll jump right into just a little bit of anatomy review. So next slide, please. We won't spend a lot of time here since most of you should know your anatomy. But what Doc and I wanted to highlight here is some structures and muscles within the lumbopelvic region that can be drivers of clients' pain or discomfort within the clinic. So if you look at the top left, it's highlighting the piriformis muscle. This muscle functions as a lateral rotator of the hip when it is extended, and it helps with abduction when the hip is flexed. So clinically, we look at this muscle mainly due to its proximity to the sciatic nerve. The piriformis becomes tight. It may exert some pressure on the sciatic nerve, producing that radiating pain down the lower extremity. Second muscle we wanted to highlight is the glute medius. This muscle is the prime mover for hip abduction, but due to its fan shape, it also works to assist in flexion, medial rotation, extension, and lateral rotation. So putting these actions together, the glute med works to maintain frontal plane stability of the pelvis, making it extremely important in weight-bearing activities like running, walking, and some single leg support. So if we're looking at that, there's a big relationship between a weak or dysfunctional glute med and some lower extremity conditions that we monitor in the clinic, like Trendelenburg gait, GTPS, as well as maybe some future indicators for any type of lower extremity pain or future injuries like ACL tears. So now we'll dive into our main case study for tonight, Miss Gigi Maximus. So just quickly, she's a 67-year-old widowed female who lives alone and came to see me originally experiencing a history of right-sided buttock and lateral thigh pain. Go to the next slide there, please. So I know I just gave you quickly like a sentence intro, but is there anything else you guys wanted to know about Miss M? And then we'll dive into it there.
Any particular movement that makes the pain worse or better?
Yep. So we're looking at like main subjective questions or objective, or let's start with subjective that we would ask right off the bat.
Probably want to ask how long they've been experiencing this problem, if it's happened before.
Yep. We'll go with one more before we jump into what we normally find here.
I'm not sure if it was on your first slide, excuse me, but the precise location of her pain that she came in for.
Yep. So Brandon, let's go to the next slide there. So we kind of want to look at the past medical history, social history, looking into her like support system at home if she has any, family history, medication supplements, any investigations to date, any treatments to date that were effective. That way we can kind of formalize our subjective and kind of create this story moving forward. In regards to her medications and supplements, she's taking some for her blood pressure, mood, sleep, and pain. She's had no investigations to date for current complaints of that buttock and lateral thigh. So I was the first person she was kind of coming in to see for that. And her current treatments to date included some medications for pain and coming to see me for physio, both of which provided her with that short-term relief, but nothing that was prolonged or getting rid of that pain. So based on that, let's just kind of go over maybe how we would structure our objective exam, or what should we examine next from there. If anyone has any suggestions.
I mean, just by looking at the skin, is there any skin discoloration or like swelling, changes in color, redness?
I would also have a look at gait. Initially, is she using any, it doesn't sound like she's using any gait aids or anything, but just her gait pattern.
Yep, seeing how she like functionally moves. Yep. All right, Brandon, we'll go to the next slide here. So yeah, basically when we're in clinic, we want to look at 5 main kind of areas. So people mentioned observation, then looking at breaking down mobility of different segments, looking at the lower extremity through some muscle testing, maybe some dermatomes, and again, how each joint is moving, and then some special tests. So just, again, highlighting some special tests we did. We looked at, or I looked at, sorry, myotomes, dermatomes of the lower extremity, any neural tensioning, and then the lazuli cluster, which includes, if we don't know, the SI distraction and compression, thigh and sacral thrust, which are trying to help rule in or out if the SI was the primary pain driver. That way we can start to kind of funnel in our objective exam. So we'll go to the next slide, please. So big things based on the physical exam that I wanted to highlight was there was no gait aid. I didn't mention that, but she had a slow and cautious Trendelenburg gait with a decreased stride length and stance phase on the right side. So really kind of favoring that right side. Her lumbar spine range of motion showed decreased flexion, limited by patient reported pain. So she was very hesitant to do any type of movement, especially in that forward flexion. Her right single leg stance, she was only able to hold for 10 seconds before onset of pain. Her hip range of motion was limited to half in all directions, again, due to patient reported pain, and that was through passive range of motion. Her hip muscle testing showed decreased strength, again, limited by pain. Patient was very hesitant to move. And then she had tenderness over that greater trochanter and her glute med. Next slide, please. So I know it's difficult when the patient's not right in front of you and you may have looked at or asked different questions than I did, or given the information we got, but can anyone give us some ideas on some differential diagnosis they're formulating right now? Scott, I don't know if you're, oh, sorry.
Sorry,
Go ahead.
Osteoarthritis potentially.
Yep. I was gonna call out Scott. It'd be great to hear what you were thinking.
Pardon me, in the lower half of your objective findings made me think about piriformis that we discussed already.
Yep.
Pattern 1, mechanical low back pain with a potential radiculopathy.
Yeah, that's a great one. We'll go one more from a fellow physio here at LiveActive. Anyone want to help me out?
Maybe some sort of tendinopathy.
Yeah, for sure.
Can I ask a question? I'm just curious to know, I didn't really look at it or see it on the history, but does the person have osteopenia or osteoporosis?
No. All right, so we'll jump to the next slide. So these are kind of the 4 differentials that I thought of initially. So we have that GTPS based on kind of the location of her pain, the gluteal tendinopathy, which someone mentioned here, hip OA, which someone also mentioned, and then that referred pain from either the SI joint or the lumbar spine, based on, again, the location and the objective exam. So if we look back at the patients, so now we're going to talk about kind of initial physio management with this client in particular. So if we look back at the patient's social history, and again, it's hard to say because you guys weren't with her, but a lot of the initial management and current management to date was focused a lot on education, just trying to get this client to understand that, you know, she was very fear avoidant and was hesitant to move. And she was very focused on her pain and was afraid of any movements. So we needed to find areas that we could kind of work within and that she could perform. So we started with some isometrics and slowly worked our way up to some isotonic movements. Again, working through very small ranges of motion and trying to target the muscles around her lumbopelvic region, including hip abductors, glutes, and quads. And then the manual therapy within these sessions focused a lot on stretching and releasing muscles around that lumbopelvic region and some hip traction to help with range of motion. And she found relief from these sessions, but again, it was very short-lived. And if the next slide is just some references there that if you guys wanted to look at on kind of initial management of a couple of our differentials from before.
So thanks, Marco. So I was asked to see Ms. M sometime after Marco had already started seeing her, and she was referred by the family doc again for a worsening of her hamstring problem. And I thought, okay, and there wasn't very much else in the note. And I know it's hard, and I think a lot of family docs are feeling pretty burdened right now. But I'd wondered if she'd had a chance to see her in the office to see exactly how distressed she was. I had the opportunity to review Marco's notes and his examination, what he was doing. And so I felt pretty prepared when the patient came in, but I wasn't really prepared enough. And I'll explain that in a moment. The other thing that came out on the history was she had just moved to Toronto about a year ago. So she was still had a lot of appointments in her old town that she lived in. So driving back and forth, it took, a couple of hours on occasions. And she started talking to me about her shin pain when she was sitting in the car for too long, stuck in traffic. It was the ipsilateral side, not her edematous left leg. And she said, and then when I get up, I get out of the car and I walk around a bit, it goes away. And then when I sit down to eat my dinner, it comes back again. And I'm thinking, okay, I need to listen to this. This is a new clue here. And she really was quite distressed and said, I don't really feel like I'm getting any better. And this is perhaps even worse. And it struck me with her demeanor and, how hard they were both working at this. And it wasn't really changing, that maybe it wasn't just a soft tissue problem. Marco's being very conservative when he said she was reluctant. She refused to do some things for me and then would burst into tears. So again, I'm thinking of her history. I'm thinking of her social situation. She's had a number of losses in the last few years. Her first sentence to me when she sat down in the exam room was, "So I retired and my body fell apart on me. And then my life fell apart." So this is the point where we're starting from. And I'm thinking, oh my gosh, okay, what do we have here? But she still had findings on her exam. Yes, she still had all the different soft tissue points. She still had tenderness everywhere. But because of the shin pain, I had her do some flexion repeats, extension repeats, and side flexion repeats. And it was just like, okay, now in office, we can change the pain and we can make it worse and we can make it better. So now I'm really leaning away from this just being a bursitis, and it certainly wasn't a hamstring problem. And yet when I did some of the other sort of like straight leg raise, I did not do a full exam, I have to say. We spent so much time talking about her distress, but her straight leg raise in supine was negative. So I thought, okay, well, I'm going to go with what I have and start thinking outside the box of this being GTPS. So next slide, please. So based on those changes and based on sort of how I've expressed that to you, what are you thinking now in terms of her potential problems?
More back base, like maybe facet or something?
Yeah, it could be. She was a little bit worse in flexion though. Well, no, that's not fair. Her shin pain was worse in flexion. It didn't really change much of the buttock or lateral thigh pain.
It could be like a deep gluteal syndrome.
Yeah.
SI joints, lumbosyncoradiculopathy, maybe a gluteal component. Sometimes that superior cluneal branch will present laterally over the thigh, upper thigh, and over the greater trochanter area.
Yeah.
And it tends to be sort of aggravated with a prolonged period of sitting or reaching for someone's toes. So it doesn't quite, fit. Ideally, I don't know that I would put that at the top of the list, at least not in isolation.
Yeah, I agree. There's features here of a few things that I think, and her pain intensity made it very difficult to examine her. So I think that made it harder, and it was, it was hard not to be compelled by her distress, quite frankly. So because of the shin pain, I'll be honest, I thought, maybe we're dealing with the radiculopathy more likely than some of the other less common things. She definitely had tenderness over that greater troch, so I think we had to keep that there. And she certainly could have more than one diagnosis, right? I think, we don't need to have all our chickens in one basket, as it were. I still wasn't sure about whether or not this was largely a pain amplification problem. She already had been given a diagnosis of fibromyalgia by somebody. That doesn't mean that, she should be histrionic, or she may just be in a lot of distress. But she was very distressed this day in office. And I just thought, I'm not sure. I'm got evidence of one thing on objective findings, and yet the presentation is still difficult to tease out. Because somebody's told her if she's getting cramps, she should take magnesium. So I said, sure, go ahead. And she was a little adverse to taking medication. Her family doc had given her a baby dose of pregabalin. She didn't like it, so she didn't take it. So we compromised on her like a a very modest dose of a non-narcotic, just regular dose of acetaminophen, but I did get her to start experimenting with some prone lumbar and hip extension postures to see if that would help. And I thought, you've had months of pain, I want some tests, so sent her off for x-rays, and pending those results, teed up an MRI once I got the x-ray results back. Would anybody do any other investigations at this point?
I don't think there's anything that's sort of sticking out like a flag for necessarily like an overall systemic thing. I was just trying to remember what we sort of had talked about. And I think the x-ray would be probably my first step too, and then the MRI pending what the x-ray shows. So I've decided no.
Would anybody do nerve studies at this point? This is a bit unfair because all our therapists, may or may not have someone's ear to ask for these sorts of things, but docs on the seminar, would you order anything beyond this at this point or wait?
X-rays are fairly quick to get, so I think I'd do the X-ray first. Maybe consider an ultrasound if your thinking goes back towards that greater trochanter or tendinosis or something along those lines. But I think that's a reasonable start. It won't delay you much to reassess and put in a referral for an EMG in 3 days, 10 days, 5 days, whatever it may be.
Yeah, depending on what gets back for sure. And I think if the pain wasn't so disparate and if the shin pain didn't seem to be so reproducible in office, certainly if I was thinking of injecting her for greater choke, I might have ordered an MRI or sort of an ultrasound, but it seemed more complicated than that. So I didn't even think of it, quite frankly. But yeah, if it was a simpler presentation, that's often very helpful. So we did get the x-ray fairly quickly. She actually had to take an Uber to the x-ray because she couldn't drive that day. She was in such bad shape. And it showed some findings, a little bit of spurring in her hips, so probably not enough to cause the amount of pain she was experiencing. Although uterine cancer rarely metastasized to bones, I was happy to see that there was no metastatic lesions because the body doesn't read the textbooks that we have. Her SI joints were fine. She did have some degenerative disc disease at 4-5 and 5S1 and some degree of scoliosis, which I don't think either Marco or I noted in our notes, but certainly if you've got some muscle spasm going on, is that structural or is that functional? We were able to get the MRI fairly quickly afterwards. So you can tell this was a while ago since MRIs seem to be backed up these days. And the radiologist there said, in fact, that her lumbar spine probably should be numbered differently. And he thought there were changes at 3-4 and 4-5. But this is now starting to be clinically compatible. Her radiological findings are starting to match her pain, where she's presenting with pain. And now it's sort of, in my mind, suggesting, no, this is probably a radic as opposed to just stroke bursitis or glute tendinopathy. Next slide, please. So what do we do next, folks? Here we have this lady. We've got maybe a better sense of the diagnosis now. She's in a lot of distress. What would you do next? She's had some education, lots of education. She's been given ideas about positions of relief. She's managing to the best of her ability with that. Not a big fan of medications, taking a little bit now and regular dosing, but very low potency. So not expecting a whole lot from that. And she's had months of symptoms at this point, not functioning.
She could be a reasonable candidate for an interventional procedure, both for symptom management, but also for diagnostic purposes. So it would kind of be a twofer.
Yep. Yeah, for sure. For sure. These two references that I put up here, they're just they're not particularly spectacular, stellar. One is more from neurosurgical perspective, but again, the non-surgical approaches is really education, stressing self-management strategies, and then using a variety of medications as appropriate or helpful, and various physical therapy strategies appropriate or helpful, some with good evidence, some with poor evidence. And so we were doing that. So I was really sort of going, okay, what are our next steps? So between the time that we got the X-ray, ordered the MRI, and got the results back, I had started on nortriptyline, and I use nortriptyline as a pain modulator if I don't think it's neuropathic pain. And because I was still a little bit up in the air on that, I thought, okay, I'll give her a trial of that. She didn't like pregabalin. Let's try this. It's different. If it works, it's a bonus. And it did not. So we had discontinued that. I think the day she went for her X-ray, she ended up in Emerge yet again. Or maybe after the MRI, I can't remember. But the Emerge doc who saw her gave her some ketorolac, and she found it very, very helpful. So this is not a go-to medication that I would prescribe in office, and I think people do come home with that from Emerge instead of a narcotic sometimes these days. But I did get her to go back on pregabalin at a much higher dose. She was on a little, baby dose of 50, and so we were able to titrate that up, and I think that helped a little bit. We reiterated all her pain relieving positions, which she was, doing some of the time. She was still seeing Marco. Was there anything, Marco, do you want to update us on what you were finding helpful for her at this point?
Yeah, for sure. So after she saw a doc, the focus kind of switched more to that lower back. So doing some lumbar traction, some lumbar pivoms, and that helped around that area of irritation. But there was still a big focus for her on continuing to strengthen the lower extremity in some of those pain relieving positions. So maybe stepping back to more of those isometrics, because she still came in wanting to participate in some ADLs, dog walking, and some family activities. So still wanted to put the focus on the movement, but yeah, some of the manual therapy changed up.
Can I ask a question?
Please.
Yeah, how did she present, like from mobility wise? Was she actually able to do stuff on her own? Or she's bedridden, or she's really just coming to physio and going straight home, sitting on the couch?
Yeah.
Was there an opportunity to prescribe stuff at home for her? Is what I'm asking.
Yeah, that's a great question. So there was a very, for her, small window of the day. So usually it was wake up and first thing she did was walk over to physio. She lives. And then from there, once she was up, it would be a dog walk. And then she would have to lie down for probably a few hours, she mentioned. And then it was get up and try 1 or 2 exercises if she didn't have another appointment or family function to go to. So it was very much so once she got up for the day, she tried to pack it all in the morning before she got too tired or irritable.
So in the end, what I did with her, because and I'll explain why in a second, Megan, I didn't do what you suggested, which was another option. But I decided because we already had the MRI and neither Marco nor I felt we were making any progress, I did refer her to the Rapid Access Clinic for low back pain. Next slide, please. And Dr. Candelaria, are you still on with us tonight?
Yeah, I'm here.
Can I impose upon you to share your insights and to let our audience know about the Rapid Access Clinic? I think you were there from the beginning.
Yeah, I've been there for a long time, actually. I'm a chiropractor. I've been working with the Rapid Access Clinic since it was a pilot at University Health Network in 2012. And luckily, we sort of moved beyond the pilot phase and received provincial funding. I think it was in 2016 or 17. And rolled out formally across the province by 2018, 2019. At various different times throughout that time period, we had 16 of the regions coming online. The province is divided up, or was at the time divided up into 16 LHINs. Now it's Ontario Health Teams, I believe. And so we see people who are sent by primary care providers where it's on paper, it's technically a spine surgical triage program supporting primary care management of low back pain. But I think anyways, I have my biases obviously, but I think we do quite a bit more in terms of education. The focus is on education, self-management, supporting manual therapy and rehabilitation professionals in the community who are working with patients, trying to provide essentially a second opinion to support them, supporting primary care, of course, and determining if the person needs any further more expeditious types of interventions or consultations. Rheumatology, we have affiliations with rheumatology. service. Dr. V, I believe, is on the line as well. He's one of our interventional groups that partners that we use as well as part of our management of patients, and providing and supporting people with expedited consultation and, if needed, intervention via injection treatments under guidance. We have affiliated radiologists to support, second opinions with respect to reading imaging. We can access imaging on a fairly expedited basis. I mean, it's all relative. It's the Canadian healthcare system after all, so it's all relative. We try to make it as quick as we can, and it varies by region, but I oversee the one in Mississauga-Halton, and I'm usually we can turn around an MRI, and I'm usually consulting the patient back after the image is ordered within about 4 to 6 weeks. And with great partners like Dr. V, we can usually get people into certain places very quickly, and it tends to serve the patient well. The focus, of course, is always on the self-management approach. I think, I like to say we think we do a pretty good job.
Thanks, Henry. I appreciate that. I think you do too. I was part of the initial referral network when the pilot started. And that was launched by Hamilton Hall, Raj Ramprasad at UHN, and Dr. Julia Lane, primary care support. And if anybody is watching and wants to know, next slide, Brandon. There is a training module that you can do, so primary care physicians can now refer directly after they've done a little bit of a training module. It's very easy to do. Next slide. So when I sent Ms. M to the rapid assessment clinic, she was seen downtown, and in fact was fast-tracked to see spine surgery. She's continuing to do her best as she's able at home with her exercises, in clinic with Marco. She's still using her meds. It was suggested that I crank up the Lyrica to a higher dose, so I did do that. Her surgery is being booked. But certainly other options would have been interventional. And I think if we hadn't been able to get the MRI as quickly as we did, I would have gone that route to see what, because as Megan said earlier, it's partly therapeutic, but it's partly diagnostic as well. And if you've got time on your hands and you can't sort of get the patient moved along in the care pathway, then this is a great second piece. And there's places in the community right now where you can have your patients seen very quickly. We're very, very fortunate in Toronto, and I don't pretend that it's province wide. So I will not move from Toronto while I'm working, because it's a great place to get care for patients. Next slide.
Laura.
Yeah.
I thought I might add one more thing to the last point on your previous slide.
Yes.
Especially given that this case, we've got that transitional vertebra. That's sort of a, for me, we see spines all day. We don't do much in the periphery. But it's sort of a neat mechanical variant. So when somebody has that transitional vertebra, you can have a little bit of extra force, almost like an autofusion at the level above. And it seems that some of that was manifest in this patient's case with the with one side of her disc protruding rather than sort of a broad bulge. And in addition to it, as Megan was saying, the diagnostic portion can be utilized if you're trying to fine tune or tease out what you want the surgeon to do. So in some cases, for example, they may take the approach of doing a discectomy, going after a particular route, or you're thinking maybe it's an L5 or an L4. We can freeze L5, leave the patient be, have them get up and say, hey, how do you feel? Yeah. I can say, I feel 30% better. We can go after L4. They say, I feel differently better. And so the surgeon knows they need to do 2 levels instead of 1. Similarly, if that transitional segment isn't fully fused, we can put local anesthetic in the pseudoarthrosis and have the patient say, hey, I don't feel any different. And then if that's the case, the surgeon has no reason to cut that portion of the bone. If they say, wow, what a world of difference, the surgeon has some direction. Or the radio frequency ablations and for the axial components for the facet or for the segment itself. So they don't really have to feel that painful segment of bone.
Yeah, that's very helpful. And I think, I always sort of think of the next fastest thing, but this is certainly very helpful because certainly the surgeon would have had more information than what he has now. So I'm curious to see what happens and what levels he then does surgery at and how she does afterwards.
I also, when I was working with Raj, we definitely had a patient that he'd booked for a microdiscectomy like the year before I was a resident there. And they underwent a nerve root injection, had terrific results, and then managed to essentially rehab beautifully, and then had an issue in, I think it was like something personal where he fell off the rehab wagon. He'd been really committed to his core exercises, fell off, and then had a recurrence of symptoms like a few months later. And then by the time we saw him back in clinic, he'd gotten back on the rehab exercises and had almost a full resolution. It was amazing because the MRI was like, he was gonna operate. And so it was interesting to see how effective that was for something that we thought was very, very likely surgical.
Yeah, I was a bit concerned about this lady developing chronic pain with the presentation. And so I was going to chase whatever was fastest. And it happened to be surgery. So we'll see. Story's not ended yet. Thanks, Megan. That's an interesting feedback. Not too many primary care docs here, but this is just the core back tool that evolved around the time that the rapid access clinics were evolving and in pilot, and it was updated in 2016, so it's much easier to use. So this is my default with my family practice residents, when some of them now have never examined a patient's back ever in their training in their second year family because of COVID. So this is something I pull out for them. Next slide. And these are just some of the resources. And in the old days, way back in the old days, we did not have interventional pain in the community that had fluoro. There's a smattering of folks that were doing ultrasound, but there wasn't really access to fluoro. So we were dependent on the very short hours available at the hospitals. Some hospitals have a stronger interest. Their radiology is more interested, so you can still get that done timely. Silver Pain Clinic, and then Dr. V's Boer Pain Specialist. I think that's a great resource in the West End, but I've got people coming from the beaches going out there because they have family out there and they don't mind the drive. There's a couple of other clinics that I haven't used, but again, I think our community-based resources are plentiful and we're very, very fortunate. So that's all I had to say. Marco, did you have anything else you wanted to add?
No, that was great. Thanks for the contribution from everyone there. And thanks, Doc, for wrapping that up.